Now let's move to our clinical topic. Our speaker today is Dr. Joy Poskozim, a general dentist from Chicago. She's a graduate of NYU and she completed a GPR at the Woodhull Medical Center in Brooklyn. And then she also completed a program in dental care for geriatric and special needs populations at the University of Pacific School of Dentistry. And she's earned a fellowship with the Special Care Dentistry Association. She is also a certified dementia practitioner. So I would have to say that she is exceptionally well qualified for our program today, which is dental care for the early onset dementia patient. And I believe, Roger, that she's also going to address the issue of discounts for senior citizens. So Joy, take it away. It's all yours.
Now I am for sure. Fortunately, both the patients I'm talking about today both had insurance, so we just had to collect copays. Woohoo! All righty. So I started off today. There was a request from the last time that I spoke to discuss the actual cases that I see on a daily basis. So so I have two patients today, and the first one, if we can go to the next slide. It has Parkinson's disease. And to discuss Parkinson's disease, we also have to remember that it is one of the dementias under the umbrella of the term dementia. And as a quick reminder, nerve cells in the basal ganglia, an area of the brain that controls movement, become impaired and or die. And normally these neurons produce dopamine. And when the neurons die or become impaired, they produce less dopamine, which causes the movement problems associated with the disease. And unfortunately, even as today, I was going through my slides and reviewing the research, the cause of the neurons to die is still unknown. Next slide. So we're going to use the name Cesar. He had come in with his daughter, and he is not happy with his smile. As you can see, his lower lip protrudes out over his upper lip, and that's because he's missing some upper teeth. And he's realizing that he can't chew the foods that he wants to eat. He wants to eat the foods that he wants to eat. He's not able to do that. He's not happy with his lifestyle at the moment. He's beginning to lose weight. And the daughter brought him in because she is a patient of mine and knows that I treat seniors. Next slide. So he's 79 years old. And per other presentations that I have done, the medical POA versus the financial POA, power of attorney, is really important to know at this stage of the game, because even though he is the subscriber to his insurance because he was a mailman, he is not taking care of his finances. So when we're discussing the treatment for the patient, we not only have to look at who is going to be approving this treatment, but also who's going to be paying for this treatment. And even though the daughter may approve and say, yes, let's do this kind of treatment for the patient, it really is, in this case, the son who is going to be paying the copays for this patient. And it's really so important to make sure the right hand knows what the left hand is doing, and to make sure that that everyone's on the same page, that they're talking to each other, that there's good communication, not just dental office or doctor or myself with the family, but that the family are talking with each other. He lives in an apartment with a 24/7 caregiver. So it's usually 2 to 3 different caregivers depending on the shift that they have. And this is really important. I'm going to give you a little heads up. I make him partial dentures. So it's really important that it's not just the one caregiver that knows about the partial denture and how to take in and take out. It's also very important that all three of them know, that all of them are on the same page too. So now we've got the patient, the daughter, the son, and potentially up to 3 different caregivers that have to be aware of his dental treatment in order to make sure that the teeth that he still does have will last. He has not seen a dentist in a long time. He's missing teeth, making it harder to chew, and he wants new teeth and to smile again. So next slide. Next slide, please. Do we have a next slide? Okay, there we go, Cesar. So Parkinson's, he's had Parkinson's for 18 years. He has the typical shuffling gait, but he is still walking on his own with a cane. He has minor tremors in his hands and his head. His head does move, but fortunately, the benzotropine he's taking orally, 3 times a day. He's taking the selagalene. I don't know if I said that correctly. Is being also taken. He's taking it orally at breakfast and at lunch. That particular medication is great because it helps with the Parkinson's disease, but it also helps with the depression that may or may not go with it. And unfortunately, Cesar does have, he's very depressed. And so therefore he does take this on a BID, and he's been taking it for a while. And then he's on the lisinopril for high blood pressure. Next slide. So these are his x-rays. They are, and I do blow them up further along. I go by quadrant. So these are the x-rays that we have. As you can see, we've got some lower anterior interproximal decay. We have upper right bridge that is failing. We have number 15 on the upper left is also broken down. Fortunately, there doesn't appear to be any major periapical pathologies, which is wonderful. But you can imagine that these teeth are not really great for him to be chewing and using. And he also obviously has some bone loss on those lower front teeth. Next slide, please. So we start with the lower ones. And with these lower front teeth, by looking at especially 22 and 27, you can see that those teeth on the distal, the decay goes below the gum line. So in those particular situations, I'm going to want to make sure that I use the SDF. It's going to be very, very, very difficult for anyone to get in there and remove all the decay that's there. Am I going to do crown lengthening? No, not in this situation. I don't think it really requires it, especially since we have silver diamine fluoride to use. We can isolate the area. We can use a spoon excavator to clean out the softer decay that is part of those teeth. And then we can apply the silver diamine fluoride. And then of course, fluoride on top of it. And then for the other teeth, I wanted to do, because there's obviously interproximal decay on 24 through 27. On the mesial of 27, I felt that I could use the silver diamine fluoride as well as composite on top of it. Next slide, please. So these are the different types of this silver diamine fluoride. On the left, it says 2-step. On the right, it meant to say 3-step. Sorry about that. The Elevate is what is used it is the silver diamine fluoride with the fluoride varnish that is placed on top of it. And then on the right-hand side, you see the Reva or the Reva Star. The gray compules or capsules is the silver diamine fluoride. And then the green compules are what's used for as potassium iodide, and it's used to cover up the silver color to make it not look as tarnished, so the tooth doesn't discolor as much. And it's, like I said, it's meant for more for the anterior teeth where you can apply it. And then for either one of these applications, you can put composite material over it. And then the fluoride varnish if you so choose. I will also say that for both of them that I feel they work equally well. I do not have any sponsorship from either one of them, and I have used them both interchangeably. Most often I use the Elevate for the posterior teeth, and the Reva I use more for the anterior teeth. But suffice to say, they both, as far as I'm concerned, are equally well. One more thing I am going to say about the SDF products, in my experience, has been that occasionally, and it's in the literature as well, that there may need to be a second dosage applied that the first one didn't take. In my situation, the ones where they didn't take are when the area wasn't necessarily very dry. And in the situations when I'm going into nursing homes and using these products, I was just in a situation last week where I applied the silver diamine fluoride. We applied the fluoride on top of it. Unfortunately, we did have to hold her hands in order to do so. She had a cavity, tooth number 28, class 5. And we applied this material. She's in memory care, and we brought her to the lunch table because in about a half hour she was going to have lunch, and there was other people there, so she was going to socialize with them. And she wound up taking the napkin and wiping everything off this tooth. So we had to start from scratch. It's really important that we allow the teeth to be dry, if possible, to isolate the area, to do at least 2, if not 3 coats of the SDF, and then apply the fluoride immediately afterwards, the fluoride varnish immediately afterwards, to make sure that we've got a nice coating on top of it so that the SDF can actually do its work. Next slide, please. These are some other fluoride varnishes, or some of the fluoride varnishes that can be used. On the left is Elevates. They've got hydroxyapatite in there. There's 3 different flavors: the bubblegum, the caramel, and then the mint. I show the Centrix because that's the one I use in my office. Why? Because there's a lot of it in there, especially for adult teeth. I really like that. So I'm applying the fluoride on top of the SDF, and then I'm applying it everywhere else because it's necessary. And because it's got a lot of flavors. But once again, I have no ties to Centrix. We just happen to like the choices of flavors for our patients, for both our little ones and for our seniors. And the seniors get it, well, they all get a kick out of it. Next slide. And then there's other fluorides you can use, right? I just threw another, 2 other ones out there. There's the MI varnish. I'm sure we're all familiar with these, right? We know what the MI varnish from GC America does. It's got the recadent, the casein peptide, which occurs in milk and binds to teeth, mucosa, biofilm, which allows the ACP to be stabilized until it reaches the teeth to recalcify tooth structures. And recalcification or remineralization of the teeth are 2 really big hot terms right now when it comes to fluoride toothpastes. That fluoride now remineralizes the teeth. Well, I think we already knew that, but somehow our toothpaste companies have gotten a hold of that term and they're putting it on their boxes. But yeah, so that's what the MI varnish does. For those that obviously can't be taking any milk products, not the best choice. To the right is the Vanish varnish from 3M. What's cool about that one is that it releases fluoride over 24 hours. It also has the tricalcium phosphate in addition to the sodium fluoride to help with the remineralization of our teeth. Next slide. So this is how the patient presented to me. This is how Cesar presented to me. That is not fluoride on his teeth. That is his teeth from having dry mouth. So that is his saliva. It's thick, it's ropey, and this is a really good indication of the reason why he got those cavities in the first place. The saliva is not doing its job, which is to help have a good flow through of his saliva in between the teeth. So stuff is obviously allowed to stick in there. He also has a sweet tooth, so he really does like to eat sweets. So you can imagine the sugar coating that is forming on these teeth, as well as the coffee stain that he has. Next slide. So this is me after I have put on the, I've cleaned out the areas. You can see that is tooth number 24 on the mesial, where I have cleaned out the area already. And I have placed the silver diamine fluoride in this situation because, like I said before, it's an anterior tooth. I'm going to use the potassium iodide. And I wanted to show what it looked like when I placed the potassium iodide on top of it. It does have that white appearance. It does allow to show where it is taking effect. And it allows me to see that it's quote unquote working, and I can move on to the next tooth. Next slide, please. Same thing on over there. I have applied the potassium iodide in that area, specifically on the mesial of tooth number 27. And like I said before, for number 27, I was just going to be using the SDF without doing any composite on top of it because that decay that as you can tell, that top part of that tooth, of that cavity on the distal, I could not take off. That was hard. It was only a little below that. You can see the difference in where I was able to spoon excavate some in the material out. And then after that, I was able to apply the SDF and the potassium iodide. And I did apply it slightly below the tooth. Next slide, please. So this is what we did for the upper right. You can see that on the upper right-hand side, that bridge is failing. So we removed the bridge teeth number 3 to 5. We wound up making an upper partial denture, plastic base denture with the wrought wire clasps. This is after I extracted tooth number 15 as well. You'll see that on the other side. But patient had a hard time with inserting and removing it. And we, had to show the daughter how to do it, show the caregiver, so she could show the caregiver. I never met any of the caregivers in this case. It was always the daughter pretty much taking care of this situation, but then also translating to the caregivers, because just like Cesar's primary language, all the caregivers spoke Spanish. So this was very important to make sure that, the daughter was always there, and she was in the room every single time, and was then it got to the point that she was taking notes, and we were able then to communicate with her through, her being the interpreter or the translator to Cesar's caregivers. And Cesar understood English pretty well, so he and I could communicate pretty directly. Next slide. There's number 15 that we extracted. Why did I use a plastic-based denture? Because I felt that because it's the first time that he's going to be having a denture in his mouth. He had never had a denture in his mouth before. I felt that it was going to be lighter for him and potentially easier because it is semi-flexible to get out of the mouth. I did not use a flexi denture because with the flexi dentures, at least with the labs that I'm using, that the clasp, I wanted to make sure that the clasp was wrought wire clasp. So that we made a plastic denture, wrought wire clasp, and we were able to hopefully get the partial denture in and out of his mouth, if not through him, then through his daughter and our caregiver. Gladwell was very helpful in that situation. But yeah, so I used a plastic one. I did not use a flexible one, and I wanted to make sure it had wire clasps. Why? Because I wanted to make sure I could adjust it if necessary to make it slightly more open if that was important, to be able to have a easier in and out versus the acrylic clasps where you have no control over. Yes, they are flexible, but I also felt that it was easier to use those clasps, the metal clasp, to take in and out with less chance of breakage. Next slide, please. So 9 appointments it took in order to get this far. The first appointment was obviously the diagnosis and treatment plan with the daughter. The second appointment was the SDF. The third was removal of the upper right bridge teeth. Fourth one is removal of the upper left teeth. And I'm sure you're wondering, well, why didn't I just extract them all at the same time? You have to remember what this patient is going through. He's got Parkinson's disease. It is very difficult for him to stay not moving in the chair. He is constantly moving his head. He literally has to sit on his hands, so his hands don't cause a tremor and distraction for either myself or my dental assistant. It really strains him, and it really causes a lot of fatigue for him to be in the chair for a long period of time trying to not move. So that is the reason why we definitely broke these appointments up. We also, especially with the first and second appointments, we wanted him to get used to us. We wanted him to trust us, that we were going to be able to provide him the care that he deserved and needed. And that's why I did the simple stuff first, so that he would, like I said, trust that we would provide him the best treatment for him, and that we weren't out to hurt him. We took the initial impressions for the upper partial, lower partial 3 weeks post the extraction. I always use stock trays with medium body. I skip the alginate anymore. I go straight to medium body, even for the initial impressions. And then the second impressions with the custom tray, medium body, wax rims. We did a try-in with teeth. We inserted the upper partial. He could not handle both the upper and lower at the same time. He felt that there were too many teeth in his mouth. He was very uncomfortable. He was very disgruntled. And it was right around this time that he was also diagnosed with dementia. So on top of the Parkinson's or one type of dementia, he was now diagnosed with the second one. So he was beginning to get more agitated in the chair. He was becoming, he was not completely understanding what we were doing and the reasons why, even though his original request was to have teeth and to be able to smile again. So on his 9th appointment is when we inserted the lower partial denture, and it was the same material. Next slide. So this took 18 months total. Why? Because the daughter has to work. Cesar had to be in a good mood, and finding, time, making sure that we had the time for him to have him come to the office and for my schedule. So it took 18 months total. We prescribed him immediately fluoride, but it was only a 3-month refill because it's a 90-day supply due to Medicare's rules. So every 3 months we re-upped his fluoride toothpaste. And then the daughter stated that the patient didn't like taking his upper and lower partials taken out at night. And because he, we thought that it was because he felt that he couldn't do it himself. It was that lack of control, that someone had to be in his face, standing in front of him, removing these partial dentures, that he felt useless, that he didn't feel like he could take care of himself anymore. But he was eating better. He was gaining a little bit of weight, which was good. And he had a greater variety of foods to eat, which was wonderful as well. And when I was supposed to take new pictures and new x-rays for him, this is another problem that we see with our older population. He was in the hospital. So I wanted to do a 3-month, because by that point it would have been another 3 months prior to his recare appointment. I was going to take pictures and x-rays and show all the things that I did. And unfortunately, he is still currently in the hospital. Next slide. So my next patient is Gil. Gil, I have known for a very long time. He's been a patient of mine since 2006 when I bought my dental practice. At that time, he was still working. Since that time, he had retired, and I was treating him, his wife, who was also retired, their daughter, his sister-in-law, and niece and nephew. So I treat the entire family, and Gil is the patriarch of the family for sure. And then unfortunately, he was diagnosed with dementia. Next slide. So what was he experiencing? This is literally textbook of what he was experiencing. It started with memory loss. His wife noticed it first. He was having difficulty communicating, completing sentences, or finding the right words to use for what he was trying to describe. He was having difficulty with visual and spatial abilities. So obviously he had to stop driving, and his wife never learned how to drive. So in order for the two of them to come to their dental appointments, their neighbor next door would bring them in, but it could only be on Tuesday mornings because he himself was working. Difficulty reasoning or problem solving. This includes our usual habits that we have formed, in our lifetime. So meaning our oral hygiene habits. So why am I brushing my teeth? What's the point? Difficulty handling complex tasks, and difficulty with planning and organizing. Next slide, please. So how are we diagnosing these days? Well, it comes from his personal history, physical exam, lab tests. Then we've got the COG tests. You can find the cognitive tests on alz.org, alz.org. You can find at least one, if not more, different type of cognitive testing that is being used in the doctor's office. And then we have the MMSE, which is the mini mental status examination. You can also get more information on that on alz.org. And then you've got the Alzheimer's Disease Assessment Scale Cognitive Test, or the ADAS-COG. The first cognitive testing is just a general one to see if one does have dementia. The second one, the ADAS cog is specifically for Alzheimer's. So if someone, quote unquote, fails this test, does that mean they don't have Alzheimer's? Not necessarily, but 9 times out of 10, if they're positive, it's going to be Al's versus Lewy bodies, which is what Robin Williams had, or frontal temporal dementia, or one of those other dementias that exist. But Alzheimer's is still the most common one, so there's an actual specific test to that. 62% of all dementia diagnoses are Alzheimer's, or is Alzheimer's. And then there's neuropsychological testing. They do radiology tests, and they also do brain imaging, and that's the last one that they do, and that really is the significant test for brain imaging, is brain imaging. That it pretty much puts a nail in the coffin, so to speak. Next slide, please. So medications, what was he on? He's on the Aricept. This is the gold standard for all dementia patients. It's once daily. It's an oral medication. It's now, fortunately available as a generic. It's used for all stages, and pretty much they're on it pretty much until they are in severe dementia, where they are then pretty much in hospice. And once in hospice, they might be taken off that medication, and all medications at that point. And then the Nameda is used to treat moderate to severe Alzheimer's disease. Anymore, I don't see that. I see that they're being prescribed immediately upon diagnosis. Once the diagnosis has been made in the doctor's office, they are walking out with 2 prescriptions, one of them being the Aricept, the second one being the Nameda. They're being taken at the same time. Next slide, please. So this is Gil. This is him in 2013, excuse me. And in 2013, we had done an upper splinted bridge, because you can see that he's got that bone loss there. He pretty much had refractory periodontitis, and it was on the request or recommendation of our local periodontist to do this for him, as well as to make him a lower night guard to help prevent clenching and grinding, which he was doing. And so in 2013, this is his, you can see the PA. I kind of made it a little bit bigger, so it's a little distorted, but you can see that this is the upper PFM bridge that I did for him in 2013, and to keep his teeth. Next slide, please. So this is him in 2017. 2016 is when he was diagnosed with Alzheimer's. And in 1 year, you can see the dramatic change from him, well, granted, it's been 4 years, but you can see the dramatic change that has happened during that time. And, you don't see any calculus or plaque, for that matter, around this bridge. The problem is that he's just no longer appropriately taking care of himself. He's grinding now more because he's on the memantine, and he's also clenched more. And the other problem is, once again, we stop with our habits, right? We stop with our usual and customary routine at this time. So, he had stopped wearing his lower night guard. Then his wife said, it was lost. I made him another one. He wasn't necessarily wearing it on a regular basis. And his wife, who was coming in every 4 months for her own cleaning, was giving me updates, because it got to the point that it was very difficult for him to come in. However, next slide, please. We were able to send Gil to an oral surgeon to have to sever that upper bridge. And to answer one of the questions in the chat, yes, at oral surgery, he was sedated to have those teeth taken out. He didn't really have a choice. Unfortunately, he responded very well to sedation. So the wife allowed for sedation, not general anesthesia, but for sedation. And Gil responded very well to that, and they were able to take the teeth out appropriately without complications. We made him a chrome upper partial denture that he could take in and out by himself at first. We made sure that before he left, he was able to do so. But then with wife coming in for her own cleaning, stating that, he no longer could take the upper partial denture in and out. And once again, kind of like Cesar, we're not letting anyone else do it for him. And I see this consistently everywhere, to the point where someone is now being brought to a nursing home to live, which is wonderful. but there's no question, there's no requirement to say, hey, is there, anything in the mouth we should be aware of? And so the caregivers will be brushing their teeth with the partials in, not knowing that there's a partial denture in the mouth. Or maybe the director of nursing knows upon admission that this patient has partial dentures, but somehow it never gets down to the caregivers who's going to be providing the daily service, the daily care for these patients. And so if they have no experience when it comes to dental care, they don't know a dental clasp, but they've never seen one. It doesn't respond to them. They don't know what a clasp is, so they're just brushing, these teeth as if that was part of the tooth. This is where the problems arise. But the wife stated that they would brush the teeth for him with his upper partial denture in the mouth as the best they could do. And once again, the fluoride toothpaste, 90-day supply, because he's on Medicare. Next slide, please. So these are the last x-rays we were able to take, November 30th in 2021. As you can see, he healed very well. Obviously, we took the x-rays without the upper partial. Yes, he has had more bone loss, but at least we were able to have, these two retainers to be able to help support his upper partial denture, and being able to continue to use, what he had for him to be able to eat. Next question, or next slide. And so in treatment summary, what do we do in these situations? Short appointments because our patients get restless, or they have to go to the bathroom, or they begin to get disoriented and they don't like all the noise and so on and so forth, versus do we try to get as much done as possible? Because we don't know when the patient is going to progress into the next stage of dementia. We don't know if this patient is going to have problems with comorbidities. We don't know about, the caregivers being able to bring the patient into the dental office. We don't know, as a dental office, if this patient now, it's been decided by the family that the patient is better off in a nursing home. So what do you do in that situation? It really comes down to the patient. Do you, sometimes maybe less is more. Okay, well, at least we got the infected teeth out. Did I ever get a chance to make them a partial denture? No, but at least I know without the partial denture in the mouth all the time, 24/7, this mouth hopefully will be cleaner. And yes, maybe the patient's on a pureed diet, but we also know that these teeth can be brushed, and we know that this patient will have a better quality of life because we got rid of the infected teeth. This is a struggle that I have every single day with my senior citizens, with my senior patients. And it takes a village. It really does. It's a matter of discussing with the family. It's just a matter of discussing with the patient. And the patient, once again, in early stages, will have lucid moments and will want to have a say in their treatment plan. How much can we get done in a dental appointment while we are dealing with a lot of issues in someone's mouth? Because 9 times out of 10, these patients have not been seen in a long time. And it's only when it really becomes obvious to the loved ones that there's a problem that I get to see them. Next slide, please. So that's my presentation. You can email me directly at jvpdent@gmail.com. And then my website is joyposkozimdds.com. I see something about getting consent. Yes, absolutely. I always get consent for treatment from ideally the patient themselves, but a lot of times it is from the medical power of attorney for treatment. At least in Illinois, I don't need to get the consent for treatment from the financial power of attorney. However, it really depends on the state as far as I know. But yes, I always get consent from the medical power of attorney, and we try to make sure that the medical POA is with the patient at every single appointment, but that would be ideal. It doesn't happen all the time. A lot of times we'll get the caregiver to bring the patient. And then I have to make sure that that person has been approved by both powers of attorney, that the person is allowed to bring that patient in and make decisions like, are we doing fluoride today, or, how much treatment are we actually providing for the patient today?
Thank you, Joy. Great presentation, Dr. Poskozim.
Thank you.
We've got a bunch of questions that I've been gathering over the time of your lecture. And I don't know, I guess, were you reading questions off of the chat?
Yeah, I did. I just saw
Okay.
those last two.
Yeah,
Yeah.
I don't usually follow the chat because there's so much going on in the Q&A. But if someone wants to move it over to the Q&A, I'll try to ask you those
Oh,
questions.
I didn't
But
even see those. I'm sorry.
yeah, we've got a bunch here. Okay, so lots of questions about the silver diamine fluoride.
Sure.
A lot of questions about charging. Is it charged per surface, per tooth? Are there insurance codes? How do you go about making this work?
You got it. So we charge directly. We do try to charge the insurance. A lot of times when we call the insurance because of the codes, either you're going to be using a sealant code 1351, you can use a 1355. It really depends on what, if you can get the insurance to pay for it, great, then it would be 1351. But if the person's over 14 years of age, then that's a sealant code, so they probably won't pay for it. So generally speaking, to make a long story short, we charge $150 per tooth, period. Whether it's one surface, two surfaces, all six
Okay,
surfaces.
but as far as you know, there's no specific code for SDF.
No,
anymore.
I mean, if there is a temporary, you can do as a temporary application. I believe is what 1355 is. It's a temporary application of a material, a topical solution, and then you can use that. And
Okay.
but that's the closest we got.
How about for the fluoride varnish? Is that just fluoride application?
Yeah, 1206.
Okay.
Yeah, I use a 1206, and that's $25.
You know those codes.
I do.
Okay. Here's a question about using SDF with gel cam. To use those two together, and have you experienced discoloration of the teeth?
Yes. Unfortunately, even with the potassium iodide, I when you use it with the Rivastar, I still see the discoloration. It's usually kind of like a halo effect. It goes around the tooth. And we do the best that we can to cover that up. What can you do about it? If you really can get in there and drill to try to grit out as much as possible, then I see less discoloration. But if you're just using a spoon excavator, expect discoloration.
Okay. And do you place restorative material on top of the SDF? Like, could you put
I'm not going to lie to you. I normally, I shouldn't say normally. Most times I don't. I am applying the SDF. I'm applying the fluoride on top of it. I'm having the patient come back in 2 months. I want to see how well it took. I am applying a second layer. If I have to apply a second layer, I am not charging them again. I'm only charging them for the fluoride, the 1206. It's not fair. It's not their fault. We try to make it work for the patient, and we let the families know that too. It's like, look, we're not, if it didn't take, we're not going to charge you the second time just for the fluoride.
We've got a lot of patient management questions, obviously, that are down here. But one of the questions here is for a patient that's have poor compliance with your daily fluoride topical. What is there any value in a sodium fluoride tablet?
Oh gosh, I haven't prescribed that in years. Actually, that is a really good question. For the first time, I've been stumped. I don't know. I haven't done the research on that. I couldn't tell you. I'd love to come back on and be able to talk about that next time. Yeah, I don't know.
They're not designed for salivary release,
right?
They're designed to be incorporated systemically. So,
right.
So it would be interesting. I don't know either. I've never seen any research that shows that. Interesting. Yeah. Do you use glass ionomer filling materials like Fuji Extra?
That's exactly what I use.
Okay, great. Okay, and then obviously you're dealing with some behavioral issues here. So do you ever do that initial treatment under IV sedation and then try to manage behavior for follow-up visits?
Yeah, that's a great question. For both patients in this situation, I was able to do everything without any necessary stuff like that. I will use nitrous in my office. I have found that nitrous also for my Parkinson's patients really slows down those tremors. They are way more comfortable in the chair. They're way more calm. Cesar wouldn't take it, didn't want it. And so we had to do short appointments. But for those that do have Parkinson's or do have some kind of resting tremors, I've noticed that the nitrous really works very well for them.
Great. Here's a request for some advice here.
Yeah.
Have a patient who's showing signs of early dementia, like early-onset Alzheimer's, and they're still coming to the office alone because they really don't have anyone to accompany them. What do you do? These patients, they're still driving, they're still functional, but they're impaired.
How long has it been since they updated the emergency contact? Always make sure that you have an emergency contact, right, for your patients.
Okay.
If you feel that this is a problem, then you contact the emergency contact. There's a reason why that name is there. And this is exactly one of the reasons why. You have a discussion with the emergency contact. It could be a spouse, it could be a neighbor, it could be a son in Nebraska. It doesn't matter. But as long as you have an updated emergency contact, this person has been chosen to discuss treatment and discuss problems that you may be finding with this patient coming to your office. That's what that emergency contact is there for.
Great, great. You said you have the patient return to see if the SDF took.
Yes.
How do you know if it took?
Excellent question. If it's not dark and hard, the area, the actual cavity should be pitch black and really hard, almost like tertiary dentin. It needs to be nice and hard. If it's still soft, if you're able to flake stuff out, it didn't take completely, I'm going to do another application.
Okay. And how often do you apply the SDF?
After that second coat, if in 6 months, if you feel that it's necessary to do it again, then by all means, less than 10% of the time that's necessary to do that. But yes, as you see fit, as far as I'm concerned. And then of course applying the fluoride varnish on top of that.
Okay, one of our audience members has contributed that the ADA code for SDF is D1354.
Thank you. 1354. That's what I meant to say. Of course.
Well,
thank you
great.
So much.
That's some good.
But that doesn't always mean that the insurance is going to pay for it. So it's a question to be asking at when you're getting the insurance information, to be including that code 1354 to find out. But I have to be honest with you, we haven't had a good luck with any of them. So suffice to say, we charge out of pocket.
Okay. Okay. And then here's a question about your fees. You're getting beat up.
Am I getting beat up?
Well, you said you charge $150 per tooth for the SDF. So if you were doing six lower anterior, would you charge the $900, or would you do some kind of a quad fee break here?
I would probably do a quad fee break. I don't remember what I did for Cesar, but yes, I probably would give him a break. And I also believe I gave him a break on the partial dentures as well.
Okay. All right. Here's another quest for advice here. A patient is in an assisted living situation.
Yes.
Chief complaint is that she wants front teeth. She's being asked at the dining hall where her front teeth are. Made her a maxillary partial, but she's unable to remove the partial due to hand tremors.
Yeah.
Tried to teach her daycare provider how to remove the partial, but she also is not able to do this. The patient is 89. I really want to meet her need. Where do I go?
Yeah, it's a great question. So in this situation, if the partial denture can be taken out by a loved one, or if you can find one caregiver, because remember, there's 3 shifts and there's 7 days a week, they're not always going to get the same person. If you can find a caregiver on her floor or in her section that has had dental experience that you can count on, have that person routinely take out the denture when they are there to help her. If it's not going to be on a daily basis, you know what? That's ideal. But honestly, I would much rather have this patient go to the dining hall and eat with their eat with their friends and be social with teeth in the mouth, versus not having those teeth and being isolated because she doesn't feel comfortable to hang out with her friends at dinner. Yeah. I mean, honestly, I want the quality of her life. I want her to be thriving and not be sitting, in her room alone. So if you can find that one caregiver, or even, one relative or child, if you can find one person that could be there once a week to, take the partial out for them, and then, have them, clean their mouth thoroughly, make sure they're on the fluoride toothpaste. That is what's really going to make a difference for them, I think, because I want them to have a happy life. Yeah.
At assisted living, the mealtime is the main social activity.
It's social hour. It is. They love it. Yeah.
Yep. Okay. Here's a question. What do you do if your patient behaves inappropriately or even is physically combative?
Absolutely. And we get that question a lot. So in morning huddle, this is a discussion that we have. And I'm like, okay, Cesar's coming in today. Don't know how responsive he's going to be to treatment. Just want to forewarn everybody. So my associates know, we try to make sure that the patients, who else is going to be around, who else is going to be treated, in the dental office at this time. And then I work with that, the assistant, and we are prepared. So if they're going to be combative, they're going to be combative with me. I have the assistant who's more in the background and who's going to be helping me from behind. But also too, I want the caregiver in the operatory with me. I want them to see everything. I want them to be a part of it, not just for treatment purposes, but for legality purposes. If there's going to be a problem with that, I want the caregiver to be able to help address a situation, to engage with the patient. So that is crucial. And if they do become combative, you stop what you're doing. You try to calm the situation down. If you're in the middle of an actual procedure like an extraction of a bridge, you examine the situation. How far have I gotten? And we were able to take the bridge out pretty comfortably because he was pretty tired. It was at the end of the day. It was a 7 o'clock appointment. He actually fell asleep in the chair, which was fantastic. But when that happens, I always try to make sure that it's in a right time of day, caregiver in the room, the assistant is to the side, but behind a little bit, so they're not going to be the ones affected, and that it's going to be me.
Right. Okay. All right. So a couple of questions that I think we did go over. The question is, which Fuji product do you use for direct restorative? You said it was the Fuji glass iometer.
Absolutely, every time.
Extra. Okay. And then you said you mentioned you used a 3M fluoride. What is that product?
Oh, I use Eccentrics myself, but the 3M Vanish Varnish, that is the one that releases the fluoride in a 24-hour period. It's a long-term release fluoride, and that's the Vanish Varnish. And the reason why they call it Vanish is because it's clear.
Vanish Varnish. Wow, that's a marketing triumph right there.
Right.
Okay, very good. Well, listen, a lot of great questions, which usually indicates that the audience was pretty interested in what you had to say. So that's great stuff. Great topic.
Thank
We
you.
love the caring that you bring to this whole field and the information that you bring. It was very, very valuable. So thank you, Dr. Joy Poskozim, and thank you to our panel, and thank you to all of us for joining today. And we look forward to seeing you next week, when we'll have our business advisory panel as always. And our special guest speaker will be Dr. Justin Chi with part 4 of his series on understanding digital dentistry. And he'll be talking this time about digital design. So let's meet back here next week, noon Eastern time, and we'll see you then. Thanks, everybody.